This is something that we should talk about right now before it is too late. And when I say late is it's all about being prepared for the future. Now, it is a very small model when we talk about pediatric neuro-oncology and the role of artificial intelligence. But if you can just reflect for a moment before we get into this as to where does artificial intelligence really have an impact in terms of enabling, speeding up, making it precise and quick. And I think it's probably not in this realm yet at the moment, but entities like multiple sclerosis follow-up, detection of blood and fractures on acute CT scans, being able to interpret low backache kind of MRI spinal scans in a fast way, I think that's where some quick, low hanging fruits of artificial intelligence and its applications lie. But this is going to be a slightly provocative piece, which I hope to engender some discussion on, as well as after reflections on, in terms of how should a system, particularly a whole country like Africa, be prepared for or even start preparing for the future. And one of the questions I have, and I try to keep it a little bit conversational with the audience because it's a virtual setting and I can't ask you to show your hands and stuff, but does the country out there or even the continent out there have a data repository which is truly national and shared between centers in terms of these entities which we refer to as tumors? And you can use the chat function to tell me that there is not, or it's in motion, people are talking about it. And then we kind of look at where all our added value lies and a little bit of historical perspective of our own journey through understanding how big data can be used to address precision medicine gaps. So please share with me if Africa at the moment has a common data sharing agreement between all centers, because no single hospital will have more than 10 or 15 types of a particular tumor, for instance. It is all about putting the available data from multiple centers together to make sense of what that is trying to show. Whilst you're still thinking about how to answer that question, let's kind of take a little bit of a leap into the past and think about what the current issues with neuro-oncology are, because unless you define a problem, there is no point looking for a solution. Now, it is a reality that brain biopsy plus minus complete surgical resection remains the gold standard for diagnosis, characterization, as well as planning further management. Brain biopsy is invasive, it needs skill, and it can be delayed in many instances, particularly when a sampling has been done and in the molecular era, one is trying to get an accurate, precise diagnosis. Not many centers in the world still go beyond immunohistochemistry in terms of trying to assess that. Of course, surgery comes with its complications. There is a lot of focus on minimally invasive and as safe as possible surgery, and complications can happen. So there's a role for imaging in terms of helping out understanding or predicting those complications as well. And eventually, we have this constant clash between conventional imaging sequences and advanced imaging sequences. I can tell you for sure and confidently in the pediatric space, conventional imaging sequences will remain the mainstay. When I talk about that, I refer to T1, T2 diffusion, post contrast sequences at baseline, and spinal imaging, which will be more than required information compared to whatever your spectroscopy and perfusion and other things can tell you. And I think if an advanced imaging sequence has remained advanced and outside of clinical practice on a day-to-day basis for the last 45 years of its inception, then I think it is best called supplementary or complementary sequences and not advanced imaging sequences. So that was the first provocation. We looked at our own data set. This was before 2020. Essentially, the data predates the WHO iteration that happened in 2021. And this was a piece of work that looked at 550 pediatric brain tumors and how the radiologists in a center like Great Ormond Street, where we see 65% of the UK's brain tumors, either primarily or secondarily, were doing in terms of predicting the subtype. And in this, you'll see a lot of contamination of terms which have gone ahead and kind of improved themselves over time. But this is how things were in 2017 to 2019 when this audit was conducted. And a simple medical student led study in terms of what the radiologists called it, and what the histology showed at the end of it, which was the mainstay for pathology up until 2016, when other technologies became a little more in vogue. So when we looked at that data, we realized that we were still performing pretty badly in certain tumor locations like the posterior fossa. And we had an accuracy of up to around 75 to 80% in being able to predict what the possible tumor type would have been. And of course, the radiologist would use a location-based mapping in the brain, as well as use conventional sequences, particularly diffusion-weighted imaging, to be able to decide on the grade of the tumor. So 75% to 80% accuracy was pretty good. We were still performing poorly in certain areas like posterior fossa. We were still not very happy with ventricular tumors, but 80% accuracy, even machines are not achieving at this point in time. So experience, I think, still is the mainstay, and human validation models are still the mainstay as far as diagnosis accuracy is concerned in pediatric brain tumors. And of course, the output of a system is only as good as the input of that is going to be. So we have to still keep doing these measures in terms of how we are doing, in terms of trying to use prospectively these systems, particularly creating algorithms like this. This was published soon after that paper in terms of just looking at posterior fossa masses. And this was validated to the extent of a 90% accuracy rate, simply looking at the location, the ADC values, which can be quantified on any PACS system, and then, of course, our knowledge of what tumors look like. This is before machine learning could be put into perspective. Now, if you're doing 80% accuracy, and we know that most tumors are going to come out anyways, then why do we need artificial intelligence? And this calls for a further provocation and a moment of reflection as to what is the value added of technology here. And we're looking at enablers. We're looking at how we can supplement human intelligence to improve decision making, as well as improving our non invasive prediction power, not just diagnostics, but also in terms of outcomes. And a lot of outcomes in terms of response assessment are currently based on still us drawing two-dimensional measurements, trying to use rulers, when there is a lot of move towards an automated and semi-automated approach to be able to even assess volumes, for instance. And we'll come to that in a moment. Further on, it assists with management decisions. When you have big data, it's not just imaging. You have to put in there the age of presentation, the sex of the child, any predisposition syndromes that they may have, and then what the imaging shows, and not just conventional sequences. We derive information from that in terms of the radiomics associated features. And then we have the historic data sets in terms of how treatments were given, what was the treatment, and what were the outcomes. That is the power of AI, where we can put all that big data in one repository. It's not just imaging based. We can't function in isolation. We have to make sure that all multiple disciplines involved work together from the start to the pretty much the end of the patient journey, wherever that end might be. And sometimes these are happy endings, sometimes they are not very happy endings. But then when you have that historical data set in place, then response assessment, prediction of outcomes becomes easier. The next time a patient walks into the system, then at least we know that if we go with plan A, this is the outcome. If we go with plan B, that is the outcome, for instance. So there is a role, and we need to explore that. To just kind of give you some context, I will bring you three different real world examples. And it really matters to the patients, it really matters to the families of the patients. And how does it do so? So these are three different patients, okay? And I'm only showing you either a post-contrast sagittal or a T2, standard sequences here. RIA age 6, and you will tell me that that is an optic pathway tumor, most likely an optic pathway astrocytoma. You're going to be 100% right in that case. You might give a differential of other supratentorial tumors. That's perfectly fine. But this is going to be biopsied, this is going to be sampled, and then it's been either going to be debulked followed by chemotherapy. You're going to look for other associated features like NF1, etc. This is Prem, who is 3 years old. He's got a posterior fossa tumor. It looks low on T2. I can tell you that it's going to be restricted mostly on diffusion. You're going to make a diagnosis of, let's say, the possibilities of medulloblastoma, etc., in that particular space. And then when you look at a tumor like this is still in many centers across the world radiologically diagnosed, and you see that pontine diffuse intrinsic pontine glioma, which is now referred to as suspected diffuse midline glioma. You look for particular molecular signatures based on its pathology, and then you kind of plan from there. The reality is that this patient will do very well in terms of survival. They will have problems with their visual pathway. This patient will do well if surgery is clean and neat, and then surveillance strategies follow. But this patient is going to do pretty badly compared to all the three. And we know that the moment we make a diagnosis of a histone mutated diffuse midline glioma in the pons, survival is not beyond 12 months at the most, whatever you throw at it. Now, that's the current state. Did we need artificial intelligence to tell us that? No. But
No.
where else can we add further value to these is what I'll break it down to for you. First of all, terminologies. It all starts with at the core of this, there is deep learning systems. And then around that, we can start building neural networks, which is what the sophisticated machinery of computers does. And then we have machine learning. Machine learning essentially is based on prediction models. And however we want to play that system, we can create machine learning models depending on the questions that we are trying to ask. So if we are trying a system to tell us that, if you resect this medulloblastoma to its entirety, what is the possibility of a cerebellar mutism syndrome happening in this child, for instance? Or if you're resecting this ependymoma completely, which is sitting next to the corticospinal tract on the left, how much weakness can we predict after surgery? That a machine learning system will be able to predict. Building around on all of that is artificial intelligence. So it's kind of an umbrella term which takes into account rule-based and expert systems. And there really is no end to that horizon when you start looking at AI systems. But break it down a bit and try to understand these terminologies a little more to be able to make sense of papers that are being published or what people are talking about. A typical workflow to this effect will look something like this. So, the first part always is trying to segment the lesion out. And I can tell you instantly, when you think about segmentation, this is still being done manually or semi-manually in most centers of the world. So this is quite tedious. And we still haven't got the first step right in terms of an automated segmentation. And that is because every center that is publishing out there is trying to commercialize its systems, or if it is freely available, it has not been validated. And the other problem is that the tumors, particularly in children, are quite diffuse. How does a system decide what the boundaries of tumor here is, for instance, compared to edema around it? Is that infiltration or is that not? And then we are relying on very simple metrics like we only pick up the enhancing components and try to segment that out. The problem with that instantly in pediatrics is high-grade tumors do not really enhance, and enhancement is not a determinant of tumor boundaries in itself. Then we have, once we have managed to segment it in some way or the other, which is being done quite manually, there is feature extraction, which is radiomics. Now, radiomics essentially looks at patterns and little shapes and intensities within the area that is being interrogated, and it takes that information. It's almost getting a Google map image of the world, for instance, where you can zoom in into the pixelations of the world and look at individual houses and peoples and cars parked next to each other, determining then what the pattern of that matrix looks like. That is the best analogy I can think about in terms of radiomics-based feature extraction. Now, if you were to then match that to histology and pathology in the entire environment that is being interrogated, then you will get a radiogenomics model out of that. Now, remember, if you think about radiogenomics, we have been doing it pretty badly all these years. So people say that a little biopsy is taken and that confirms it to be a particular mutation. Let's give it a name. Let's call it BRAF V600E mutation. But that doesn't mean you've interrogated the full environment of the tumor unless you look at the full structure out there, which is now being done by certain centers. You really can't have a map of radiomics based features with the genomic based features to get true radiogenomics. So it's a bit of a gap that needs to be filled even in that direction. Of course, if the tumor is completely taken out, that is easier for the pathologist to give you a landscape of what mutations exist in that tumor environment. And finally, you use those features which are integrated with clinical information to be able to create your prediction models using the molecular markers and then looking at survival, which could be overall survival, progression-free survival, as well as prognosis. So that's kind of a typical workflow of what this looks like. Let's make it simpler for you. Lesion identification, molecular subtyping, survival prognostication are essentially the current applications for AI. And I can tell you that there has been more advancement, there's more scope of advancement in pathology rather than radiology to be able to use pathology based AI and machine learning systems to be able to read these slides in a much more swifter manner than in the radiology world at this point in time. And then, based on a systematic review that we published in 2023 of the existing literature, really the current applications have gone only to try and say whether this is a medulloblastoma, how to separate it from ependymoma. So very basic, still scratching at the surface. We know that there are at least 8 to 12 types of medulloblastoma now. Ependymoma itself depends on whether it is supratentorial, infratentorial, or in the spinal cord. Pilocytics have undergone a major metamorphosis in terms of how we understand these tumors. And glioma, of course, the landscape is constantly expanding in terms of how it goes. There is some good music in the background. If you like playing it, I've got no problems with that. So let's go back to the first patient, Ria. Ria had this optic pathway tumor, and you have 2017, 2019, 2021 looking at here. This is the trajectory of this patient. The problem is Ria was started on a particular treatment line, and the parents said, why was the treatment stopped in 2019? Because we think that the child has got worse. The radiology reports on this patient kept saying stable, unchanged, unchanged, stable, most likely stable, cystic, solid, stable. You know how radiology reports go. So the clinician walks in the afternoon and says to me, I really want to know what happened with the volume of this tumor. So I had to sit down and manually segment from March 2017 all the way to December 2022. Of course, that was a whole day spent doing that because there were 35 time points. I had to use some kind of a methodology, an ellipsoid technique that we use for measuring tumors on two-dimensional arrangements, even though these might not be very well-defined ellipsoid tumors. And the whole question was the parents wanted to know why tremetinib, which is a targeted therapy for particular mutations like BRAF in these tumors, was stopped in 2019. And if you put it to perspective this way, the parents were right. The treatment was stopped in 2019 and the tumor just grew back all the time, and the child's vision kept deteriorating. Trust me, the radiology report was all about stable, more or less stable, not really changed, but we were not measuring in real time, and we don't measure in real time if you think about our own practice. What we generally do is when we report September 2022, we say comparison made with June 2022 remains stable. We don't really go back to the beginning of time, for instance. 35 time points, and it was soul destroying to do that. And the question that came out of it was, could we have automated this entire process of segmentation, even when in 2022 and 2023 we were looking at it? And the answer is yes, except that the systems have not been validated. There have been a lot of papers, particularly from centers in the US. Philadelphia is leading on it at the moment in terms of automated segmentation, but all the examples that they tend to show, as in these papers here, are very well-defined tumors. And you can see it's easy to segment out the well-defined tumors. But now, 2 years on from that paper, yes, we are at the moment in our own center validating three available platforms in terms of how they do in terms of segmentation in an automatic fashion. But the first step of that still has been a human being drawing what they think is the tumor and matching it against that. So that's the current reality. But in Ria's case, if that could be done in an automated way, click of a button, imagine the power of doing that. The second thing that came into my mind was each of these 35 time points were contrasted. This child had been given a cannula, had been contrasted, and essentially, was struggling each time because the contrast itself was not helping us determine if the tumor was getting worse or bad. So, did the child need contrast? Could the need for contrast be negated? And is there any systems out there which could tell us that we could use deep learning to actually create out there contrasted images from non-contrast information? And yes, there was something that is emerging out there. People are trying to test it and validate it, where you use systems like synthetic MRI or even just some kind of a deep learning model wherein the non-contrast pictures are able to create masks, and then it is normalized to a scan, and you are able to create a synthesized full dose contrast enhanced MRI without giving any contrast or giving very limited contrast in these patients. So the leaf that we took from that here has been, we have started reducing our contrast dose. At least that can be done, right? So we give half dose in most of these cases. And we are also hoping that our clinicians agree that we can drop subsequent contrast administrations. The problem with that is industry. Most of these patients who are on trial drugs are on trial kind of regimes in terms of response assessment. And those trials are still unfortunately based on post contrast assessment of the tumor. And that is totally wrong. Not sure why that hasn't changed in all these years. We are focusing a lot more on T2 and flare based assessment of these low grade tumors where it adds value. But of course, I think one step before this kind of a deep learning rollout should be, can you reduce your contrast dose in itself? And can you drop the contrast in certain tumors, at least on standard normal surveillance scans, and not to be used on every occasion? You can at least skip it as much as possible because it is not really adding any value to most of these situations in low grade glioma tumors. And then finally, the thing that came out of Ria's discussion was whether volume reconstructions or volumetric reconstructions could be achieved using deep learning systems. And a lot of buzz about synthetic MRI has come into vogue. There is a good company that has these systems, but synthetic MRI is still expensive and of limited utility when we are trying to get all the particular sequences to look at. It is heavily based on T1 based imaging, which then gives you the other sequences and weightings. Let's talk about PREM. The question with PREM was the need for assisting prediction. Now, there is emerging literature even around medulloblastomas that you don't need to resect the whole tumor, and there are ways of managing the residual tumor. And why is that important? Now, if you have a big tumor sitting in the middle and distorting the structures around it, then you instantly run the risk of causing cerebellar mutism. And we were able to look at our historic cohort as well as prospectively validate it. And now it has been validated externally as well, whether a baseline MRI using a convoluted neural network approach is able to predict cerebellar mutism. And we managed to get a pretty good accuracy in terms of not just determining histology, etc., but we also were able to predict mutism, which is what I wanted to show you, and come back to this in a moment. So we were looking at cerebellar mutism in PREM, and we were able to create this complex neural network. And I can tell you the simplicity of this is we are only really looking at the superior cerebellar peduncles, and we are looking at the distortion of the cerebellar dentate nucleus, essentially focusing on the anatomical triangle of Mollaret structures, which have been distorted with signal or with just mass effect. And we were able to predict fairly confidently in terms of that, whether there is a high chance or a low chance of kind of using logistic regression to be able to predict cerebellar mutism syndrome. And I mean, these pictures look very nice in these presentations. You can't even read the slides, but the whole idea was to create a decision-making adjunct, and we created a toolkit out of that, which has been published in that paper that I just showed you the reference of, where you just put some very basic data points, and it gives you a chance of cerebellar mutism, and it should feed into the consenting process for the patients and the surgeons when they talk to, which makes it very personalized in cases like this. Going back to PREM, when a posterior fossa tumor came into presentation here, could we have just called this a medulloblastoma, walked with it? Yes, probably it wouldn't make a difference because it needs to come out anyways. But radiomics is able to predict histology fairly accurately, up to 92% in posterior fossa tumor classification papers that we did with the Stanford group, and of course be able to distinguish certain tumor types with fairly good accuracy as well. And radiomics in terms of predicting molecular subtyping was further work that we did. Why does it become relevant? If your center has a delayed pathology pipeline or is not able to predict most of these mutational status, you can still use imaging with a fair degree of confidence in terms of enabling that molecular subtyping as best as possible. When we don't have all the technology and we can at least predict with some confidence, then it's possible. But having said that, you can see that it's been 3 years since these papers have been published, and there's a lot of validation that is still left to follow. So virtual biopsy is what we call it in terms of using radiomics and trying to predict it going forwards. Scarlett is my third case here, who had a pontine mass, and it was a DIPG until proven otherwise. They don't enhance, as you can see. They don't even restrict, so to say, apart from having some low ADC values. The question with Scarlett was prediction. Now, I did tell you that the survival is 12 months. But we started looking at the cohort of DIPGs using radiomics, and we realized that there's a subsection that are better survivors compared to poorer survivors. And when I say better survivors, it's 48 months compared to 12 months. And we realized the more heterogeneity there was in the tumor metrics, the better the survival was. And now pathologists begin to tell us that yes, when we have the H3K or H3.1 or H3.3, there's a difference in those subgroups. But we were able to show that difference using radiomics. Again, this was an international collaborative that came out with this paper. And if you think about it, Scarlett's parents and even Scarlett herself telling them that they're going to survive 12 months and telling them that they will survive 48 months, I know it is still dismal, but at least is one piece of news is relatively better. And when parents and families go through these problems, they really are going through significant issues in terms of planning their lives. So every little helps in that case. So really, eventually, I'm just going to kind of conclude these thoughts by telling you the challenges and the opportunities there is. The poor sample size, I talked about multi-center collaborations going forwards, which eliminates a class imbalance. And also, poor sample size can be circumvented by transfer learning and federated learning. We are working on some federated learning at this point in time with colleagues in the US and elsewhere in the world, including Australia, where every center can do its own piece of work, but the system kind of is connected centrally, so whatever machine learning is happening kind of feeds into the final system. There are too many models. I talked to you about automated segmentation in itself. Validation is definitely required. So if the continent of Africa is able to create a repository of all these tumors and then be able to validate what is useful for them, even kind of from an economic and financial perspective, then I think there should be investment in that direction. And finally, as I was trying to explain to you that we have been doing a lot of these things wrongly, we need to know exactly what the matrix of the tumor entirely looks like before we can start putting radiology overlaid on it to call it radiogenomics. So I'm sorry, a lot of information there, but I thought some real world examples would have helped you and also to provoke you into thinking that there is some added value, but we need to find what the gaps are, what is being done in that space, and how we can incorporate it into our own practice. But don't forget, human validation and human intelligence will always remain superior to any form of artificial intelligence because your output is only a function of your input. Thank you.